in dental practice, and they come in a lot of different categories. We have autogenous bone, we have xenografts, we have traditional alloplast materials, allografts, biologics, and we have some new modern alloplast materials. If we were to put them in a chronological order, how they appeared in dentistry as well as in orthopedics, we would say that the first generation were the materials that were used born from animal origin, as well as the traditional synthetics. Then we evolved to the second generation, the allografts, then the biologics, and finally, some modern alloplastic materials. What are the key differences that we have with all these generations? The key difference is that the very first graft materials that were developed, they were developed so that they would have very limited remodeling, very slow remodeling. They were developed so that they would stay. They were developed so that they would be seen for many, many years, because back then, 20, 30 years ago, we believed that this was the way to go. Placing a graft material that would quickly just turn over and go away wasn't what we were looking for. And why were we looking for something that did not remodel? Because we were in need of increased density. Why did we use so much graft materials that did not remodel? Because we had issues with implant stability and implant success where bone density was low. So for that reason, we focused on using graft materials that didn't remodel. See where I'm going with that? What are we learning from what we did in the past? First of all, autogenous bone is the gold standard material. Yes, it is. We all agree with that. But let's remember that not even autogenous bone remodels completely. Look at this case. Symphysis graft was placed on the site, allowed to heal for 6 months. 6 months later, you have great bone formation and the bone on the interface between the host and the graft. However, look at that outer cortex. What does it look like to you? It looks exactly the same as it was 6 months ago. And for those of you who had your share of experience with autogenous grafts, you know that in many cases, 2, 3 years after treatment, the patients would come back with a little sequestration, little sequestrum. What was that sequestrum coming from? From that cortex that never remodeled. If I took a core biopsy of this outer cortex today, what would I see under the microscope? Dead bone. Why? Because that part didn't remodel. So, we're seeing like growing evidence of the late effects of graft materials that did not remodel. And how can these graft materials that did not remodel end up impacting the survival rates of the dental implants that we place? We have evidence, human, histologic evidence, that these xenograft particles are present 20 years after they were placed in the patient. 20 years later, they're still there. A graft particle that is present 20 years later is not vital. What is it doing? It's acting simply as a filler. A filler can be interesting for some clinical situations, but it's also important to understand that a filler occupies space that could be used by vital bone. If the particle stays there forever, it will take away space that could be used for more vital tissue formation, turnover over time, remodeling. The take-home message of this is that every time we place a graft material on a patient, we leave a footprint behind. The question is, how deep do you want this footprint to be? Is it going to be permanent, that you're going to go back 20 years later and you still see that it's there? Or you want to do something that is a little bit more superficial, that over time it can be just washed away. So, for that we have to understand the difference between volume and function. What's the key difference between volume and function? Well, let's first look at the materials that were designed to promote volume. They did not remodel. So that's what they do. Are they very effective in promoting volume? Yes, they are. Understand volume by looking at this similar type of filler that is used in the human body, silicone. What does silicone do? It basically promotes volume, but it does not add function. Can these two gentlemen now run faster than they did before? Can they jump any higher? No, but there's more volume. So what you get with a graft material that does not remodel is volume. You do not get function. And that is even more important to remember when we look at our preventive procedures, such as site preservation. If you look at the literature on site preservation, all the way across the board, what you're going to see is this. Xenograft is the most effective material in site preservation. And I blame myself for this because I did a lot of research in the early 2000s of ridge preservation. And I can tell you that the primary outcome measure of every single study that is out there was only one. What kind of graft material will maintain the ridge shape better over time? So we take the tooth out, put the graft material in, ridge measures 10 millimeters today. I want it to measure 10 millimeters 6 months from now, 4 months from now. That's how xenograft became the gold standard material for site preservation. What were we looking for? We were only looking for volume. We wanted to maintain volume. Not a single study worried about quality because we didn't worry about that back then. If you look back at the same studies and you just read it again, but just like with an open mind, the same studies agree that xenograft sites show delayed healing, most particles show signs of encapsulation, very limited remodeling. So what was happening? Filler, just like that silicone implant. That's why the ridge doesn't remodel. So this is part of a recent study that I decided to do, in which instead of doing split mouth design, I decided to do a split socket design. Take out a lower molar, preserve the septum in between, and compare two different types of graft materials. Cancellous-based allograft with xenograft. Cancellous-based allograft is the fastest remodeling allograft you can have, and here's just conventional xenograft. Put them there, cover it up with a membrane, allow them to heal for 4 months. Radiographically, you can tell the difference, right? One looks very dense, the other one looks more trabeculation at 4 months. Take 2 core biopsies, and if you're ever interested about taking core biopsies and looking at what you do, here's my recommendation to you. Waste the trephine every time you take a core biopsy. Don't try to take the core out of the trephine because you'll destroy the biopsy. Then you send to Dr. Coelho's lab, best lab for histology in the whole planet. And what do you get? Here's what things look like at 4 months. One is 50% vital, and the other one is 15. What are the key differences here at 4 months? One has remodeled to a certain extent, to a great extent. 50% at 4 months is fantastic. While the only one has only remodeled about 15. What is 15? Bone has filled in the gaps between the graft particles, but that's it. All the particles are still there. If you're unfamiliar with bone histology, all the white that you see on the second biopsy are the residual graft particles, the dead bone. What is the key difference here? First one that is about 50% now, in another 4 months, has a chance to be maybe 65, 70, 80. While the other one, 20 years from now, will be what? Exactly what it was before. Is that important? I believe it is. This is what we are faced with on a daily basis. Our ridges are barely sufficient for the implants that we have to place. And then what do? We open a jar, put some bone in there. Well, what kind of bone? The one that remodels or the one that will be there for later? Well, I want to impress my restoring dentist, so I'm going to put the one that stays there forever. Right? What am I doing? What is this? How much of that is bone? How much of that is filler? What is going to be the impact of this over time? Just stop and think about how often you graft. More than 80% of all grafting procedures done in implant dentistry are aiming at the cervical aspect of a dental implant. The most important part of a dental implant when it's in function, because that's where we're going to have this biologic seal between the implant body and the oral cavity, and that's the part of the implant that will promote protection for that implant to be successful long term. And that's where we're adding the worst quality of bone? Does that make any sense? I don't think it does. So what we're seeing nowadays in terms of periimplantitis, ask yourself, how much of that is implant failure? How much of that is periimplantitis? Or how much of that is graft material failure? Simply the graft material failed to protect that implant over time. So, what about correction? Does it make sense to use xenograft for correction of the ridge defects? 20 years ago, it made sense because we did not know better. 2019, does it make sense for you to offer this type of interface for that implant with the oral cavity? It's not because we did things wrong in the past or we made mistakes in the past that we could continue to do them. Let's think different. Let's try to think better. So, that being said, that has effects on bone. Yes, it does. But it also has effects on soft tissue because graft material particles that do not remodel, they may escape and they may now be part of soft tissue. So now you have this graft material not only negatively affecting bone, but also the soft tissue seal. Because if you have residual particles trapped in the soft tissue, this sulcus will be populated by bacteria. This graft particle will become contaminated. It will become contaminated, will create a localized inflammation. Localized infection, inflammation, and then what's underneath that, bone that is not real bone, that resorbs. For how long have we blamed residual cement as the main cause for periimplantitis? Well, what's the difference between residual cement and a dense graft particle that is left entrapped inside that sulcus? What's the difference? No difference. Both of them can cause exactly the same problem. With one aggravant on top of that the bone that is underneath this soft tissue now is also only 15, maybe 20% vital. Can it defend itself? Can it react? Does it have immune response? Only living tissue has immune response. If it's only 20% vital, you only have 20% of any potential immunological response to the plaque and the bacteria and whatever injury is applied to that soft tissue. Is that enough? No. It's definitely not enough. You may get by with a residual graft particle in the sinus 20 years later because it's just sitting there. What is protecting that implant for the last 20 years is that crest of bone that was natural. So it's just sitting there. It might be okay. Not ideal, but it might be okay.